Great. So let's begin. So this is the uh, 65th Pain Journal Club, and we are going to discuss today about the MSK ultrasound, the diagnostic value, and of course some unique perspectives. And we have some great speakers and faculties lined up. I'm going to make my presentation full screen now. Uh, so pain medicine worldwide, actually, it's quite diverse, and we are going to uh, have diverse issues, variable standards all over, different learning requirements, different offerings. Of course, money and time is something which prevents the pain physicians from getting more knowledge to help their patients. To overcome this, Mumbai Pain School is there as an initiative of Penisha Spine Wellness and Pain Relief Center in Mumbai. We focus on online platforms so that there is a low cost involved and better reach, and we are available on multiple online channels. We provide education which is mostly online, on demand, but we have most content is free. That's the main thing, and we also have some paid content. We arrange hands-on workshop. The next one is next weekend, 9th and 10th in Mumbai. We have fortunate to have expert faculties from all over the world. It says that the best teachers, they teach from the heart and not from the book. And Journal Club is nothing; it's just a club. The only difference being that the focus is on critical evaluation of recent academic literature, which is based on a defined subject, and we focus on attendee participation as well. So I request all of you to just come up with your questions, comments, suggestions, feedback, whatever you want to put in. Just type in the chat box. It's tough to be regular, so I request all of you to be regular. We are going to be here most Fridays at 8 p.m. And even Tinsley Harrison had his own journal club twice a week, twice a month, that is every 15 days, when he used to critically evaluate the recent academic literature. So time is discipline, so I request both the speakers to stick to your timelines. Healthy skepticism or praise is welcome and encouraged. So I request all of you to just give in the feedback. And of course, this is a bit about me. I am practicing in Mumbai and manage the Mumbai Pain School. So I think we go to the speakers. I'll just request Dr. Akhil to put up his slides so that I can introduce you. Dr. Akhil, over to you. Yeah, I can see your screen. So Dr. Akhil Bhalla, he's MD, FIPM, FIPM. He's assistant professor and in charge of pain medicine at Department of Anesthesia and Pain Medicine at Adesh Medical College in Ambala. He's also a founder and consultant for Painacle Advanced Pain Management Center at Chandigarh. So over to you, Dr. Akhil.
Thank you so much, sir. Am I audible very clearly? A very good evening to all of you. So thank you, sir, for the introduction. The article which I'll be discussing today is the diagnostic value of musculoskeletal ultrasound in patients with low back pain. And this is a review of the literature. And this was a review article. This was published in Medical Ultrasonography 2018, volume 20. And it was published by Todorov, Nestorova, and Batalov. And this was done in a rheumatology clinic in Capella University Hospital, Plovdiv, and Bulgaria Rheumatology Center. So coming to the introduction. So as there are many various modalities available for clinicians for evaluating low back pain, and the most common ones are MRI, CTs, which we are usually doing. And the application depends on many things. That is the working diagnosis, what is the urgency of the problem, the availability of all of these modalities, and the comorbidities of the patient. So the CT and MRI have a limitation of radiation exposure, and they show primarily the bony element. The MRI, on the other hand, shows both the bony as well as the soft tissues. And of course, its use is hampered by the duration of the examination. It is quite much. It has relatively higher costs and has limited availability. On the other hand, musculoskeletal ultrasound is a safe, very fast, inexpensive, and widely available modality. So it allows for multiplanar dynamic examinations of the system and also shows the soft tissues in a greater anatomical detail. So this was a review article where the authors made an appraisal of the diagnostic value of the ultrasound in different conditions which could be a cause of low back pain based on the available literature. So in the literature, there are very limited articles which have shown the usage of ultrasound as a diagnostic modality for various things, and they will be discussed one by one. So the first which was discussed was ultrasound and the bony structure, and the discussed part was for the spinal canal stenosis. So the first article was published by Porter et al. In 1970, and they used ultrasound as a diagnostic tool in low back pain, and they tried to measure the diameter of the lumbar spinal canal for bony stenosis. So what they did was they put the transducer in an oblique mid-sagittal plane, 1 centimeter lateral to the L5 to visualize the canal at this level. And the average diameter was found out to be 1.44, whereas for a healthy control, it was around 1.6. And of course, it was statistically significant. The cutoff value of 1.4 was proposed, and anything lesser or lower than that was put into a high-risk category for nerve root compression and pain due to a spinal stenosis. Later, in a study again by Porter et al., they published results in 700 subjects, where they measured by the same technique, but this time they did it from patients from infancy to the age of 65 years. What they wanted to show was that the canal size was relatively wider in children. It reached its maximum diameter when the people were in their late teens, and it reduced slightly by the age of an adult, late adult. In two other studies, they also concluded that the diameter by the dorsal approach which was being followed is highly operator dependent and lacked reliability in elderly people. So Porter et al. Did a 10-year prospective study, and in that they concluded that the canal size on its own had no reliable role as a predictor or even an estimator for the prognosis of low back pain. Coming to the intervertebral disc. So the most common pathologies with the intervertebral disc is either the disruption, the degeneration of the disc, or disc herniation. So for the role of ultrasound in 1989, Marx et al., they tried to compare the transabdominal ultrasound examination of lumbar disc in 50 patients with discogenic pain, and they compared the results to the results of lumbar myelography and CT. So the authors concluded that ultrasound should not be used as a diagnostic modality in disc degenerative disease. The results were highly significant, not going in favor of the ultrasound. In 2003, Berth et al., which was quite late, the largest study was conducted by Berth et al. On disc degeneration, and they again used a transabdominal ultrasound scanning. And this time they took 119 patients with discogenic pain and compared the accuracy to MRI as a gold standard. What they found that it highly depended on the level of the disc, and the sensitivity and specificity changed as the level of the disc changed. So it was higher for around L5 and S1, the sensitivity was 78%, whereas for L3, the sensitivity was just 46%. So these results confirmed the previous observations that the diagnostic performance of ultrasound in an intervertebral disc herniation, it highly depends on the lumbar level at which you are doing the examination. So the ultrasound was found to be inferior to MRI, CT, discography, myelography in detecting the disc degeneration or herniation. Nonetheless, most of the authors concluded that a transabdominal ultrasound could be used as a screening examination to reduce the exposure, radiation exposure, or painful interventions to a certain lumbar level. Coming to the sacroiliac joint. So in 1995, Burke et al., they developed a non-invasive technique. So this was a very different thing which they tried. They called it Doppler imaging of vibration, or DIV. They wanted to measure the laxity of the SIJ in an objective and a repeatable way. So what they did was they took a special device, and this device was used to apply vibrations to the anterior iliac spine of the subject, and the patients were in supine position. The vibrations were registered with an ultrasound transducer on the ipsilateral SIJ, and they processed it under the color Doppler mode. the intensity was measured indirectly in threshold units. So if there was a very large difference in the threshold units between the bones, that is the sacrum and the ilium, they indicated it to be a lax joint. While if there was absence of any difference, it was a stiff joint. The result in healthy volunteers showed satisfactory individual reproducibility and no significant differences between right and left SIJ, so it was highly significant. Uh, so there was another study by Demin et al, and they applied the same technique with in women, and especially women who have pain post-pregnancy and posterior pelvic pain. The difference in the laxity between right and left was significantly higher in women with pain compared to women without pain. So it was around 2.2 threshold units, which is significant. Later, the same group confirmed that the difference of more than 3 uh, um, threshold units in the was because of laxity of the left and the right and SIJ, and had a sensitivity of 65% and a specificity of 83%. So the positive predictive value of 77% was found out for posterior pelvic pain, which was pregnancy related. Regardless of all of these results, a later review conducted by many other authors had a thorough study of concluded that a thorough study of the validity was still missing, and so the conclusions of the DIV management should be drawn with caution. Now, this was still a sporadic kind of a study, and a more refined study was done for inflammation of the SIJ. Spadaro et al. Used a grayscale ultrasound to search for effusion in the SIJ in patients having spondyloarthritis. And 45 such patients were compared to 30 controls and compared the results as a set of clinical tests which were designed to assess the SIJ. They found effusion in 38% of the patients and only 1.7% of the controls. The positive likelihood ratio was 2.67 for patients with effusion. Closer et al. Had conducted the first study on contrast-enhanced ultrasound and showed that administration of IV contrast improved the sensitivity from 18% to 94%, whereas the negative predicted value from 72 to 94% for sacroiliitis. The limitation they faced was that this was the first generation contrast media, and it led to overestimation of the contrast enhancement. So later, Schlosser et al., again the same group, used second generation microbubble contrast agent for the detection of active sacroiliitis. So this time they wanted to show enhancement of depth in the contrast enhanced ultrasound, and the joint cleft of around 18.5 mm, the range is around 16 to 22 for clinically active SIJ. And this was significantly deeper as compared to inactive joints or in healthy controls. So what was seen was there was an agreement of contrast enhanced ultrasound and clinical rating of the SIJ. It was excellent, in fact, 100%, and both positive and negative predictive values being 100% in detection of the clinically active sacroiliitis. So where was the limitation? The problems they faced was when the joints were very narrow or with many osteophytes, as well as in patients with increased BMI. And the contrast itself, of course, has a list of contraindications. Another such study had found surprisingly high sensitivity of contrast-enhanced ultrasound, 100% in patients with active sacroiliitis. But again, this study lacked specificity because vascularization was also found in healthy controls, and that was also a bias. Hugh et al. Performed a very large study by Doppler ultrasounds on SIJ and major enthesis on the lower limbs also, and all the patients suffering with ankylosing spondylitis in 161 patients, and dividing them into active and an inactive group. And the best die scores were compared with the SIJ and the Doppler ultrasound. While there was agreement in SIJ arthritis, the agreement between enthesis and the best die scores was poor for non-arthritic patients. The vascularity pattern of the dorsal SIJs was investigated further by Zhu et al. Using the contrast-enhanced Doppler in 68 patients and 35 controls of ankylosing spondylitis. They described the occurrence of 3 different spectral Doppler patterns, being significantly more common in AS patients than with active sacroiliitis. However, in most cases, 2 or more flow patterns were simultaneously observed, hence making the interpretation very difficult. Again, for inflammation of the SIJ, Ghosh et al. Conducted a study that combined this contrast-enhanced ultrasound and grayscale ultrasound in 29 patients with inflammatory low back pain and normal X-ray and 32 controls, and they compared this finding with the MRI. They found that the observation of 3 or more signals and a resistance index below 0.06 correlated very well with the MRI proven cases of sacroiliitis. As far as sensitivity was concerned, hyperechogenicity of the joint space was the most specific parameter, 95%, while the most sensitive one was the low RI value, 94%. Although the study compared non-radiographic sacroiliitis, the proposed cutoff values for the first time, it had the limitation of a small sample size, only 29 patients, the subjectivity of counting the flow signals, which could be biased, and the quality of the equipment was questionable. In all the mentioned studies, the resistive index of the vessels was found to be lower in active sacroiliitis and to increase the treatment with it. McGrath et al. In their study of healthy volunteers found out that the resistive index increased significantly with each caudal sacral level, that is increased from S1 to S3. Thus, the exact sacral level at which the measurement might be taken was of importance, while none of the studies above have provided any such data. Coming to the soft tissues in the lumbar and sacral region. So the thoracolumbar fascia is a very huge fascia in the lower lumbar region, and it is especially strong there, which envelops the muscles in the back, and it is continuous with the gluteal fascia caudally. In the posterior layer, it has a composite structure, and it has been found as a cause for chronic low back pain. And this was studied sonographically by Lagsing et al. They evaluated 60 patients with low back pain and 47 controls in a standardized manner at only the L2, L3 level. So what they did was they measured the thickness of the perimuscular zone, as they called it, and this zone was defined as a echogenic layer, and which was located closest to the muscle's dorsal surface and separated from the nearest more superficial echogenic layer by more than around 2 mm. So in subjects with chronic low back pain, this zone was found to be 25% thicker and with greater echogenicity, and compared to controls after adjusting for the BMI. However, the authors could not explain if this was a cause or a result of the chronic low back pain. So again, it could not be used as a screening criteria. The structure under investigation in the study was not well anatomically defined, as they called it the perimuscular zone at L2-3. And this would have already included the tendinous or the aponeurotic parts from different muscle groups, as well as the perifacial fat tissue and the fascia itself. So the authors partly addressed this issue in the later study, where they divided the zone into different muscles and separated by echolucent layer. So they found that the shear strain of the fascia was about 20% less in subjects with chronic low back pain than in control. And overall, males were more significantly affected by the thoracolumbar fascia strain. Coming to the muscles in the lower back, there is not exactly a diagnostic methodology, but there is a known thing which is known as a rehabilitative ultrasound imaging, in which ultrasound is used to measure the size of the paravertebral lumbar muscles. So, as it is not exactly diagnostic, it was not discussed very nicely in this article, but the patients are examined in prone position. And what they want to do is the transducer is placed in a transverse plane on the spinous process and moved laterally to each paravertebral side, trying to see the muscle dimension, shape, and size, taking into consideration the cross-sectional area. And the piriformis syndrome is again one of the etiologies of low back pain, and this can be seen as a contracture or thickening of the piriformis muscle. The authors of this article also performed a pilot study, the current review article, and on sonographic imaging of piriformis using a 7.5 to 10 megahertz linear probe, they kept longitudinally on the muscle. There was a significant side difference between the thickness of the piriformis muscle in patients with pain compared to controls. And coming to the ligaments, the PSL, the posterior sacroiliac ligament, again is thought to be a pain generator in low back pain patients, especially in patients having pregnancy-related posterior pelvic pain. More et al. Did an anatomical study of PSL, and they visualized it as a hyperechoic fibrillar structure between the PSIL and the lateral aspect of the third sacral transverse process. So overall, they found a good agreement between the PSL length and thickness in cadavers, but this was only an anatomical study. So in 2011, Lee Goff et al. Performed a study on the PSL, and they separately assessed the short and the long portion of the ligament. And they said that the dorsal sacral nerve rami, they normally pass through the space beneath the PSL. So there, entrapment of this space was hypothesized to be the cause of low back pain. Again, all of this remains controversial whether the increased thickness of the ligament was a cause or an effect of the low back pain. And the clinical impact of these studies is that it would provide good normative data for possible future ultrasound guided diagnostic modalities. Coming to the last, the iliac crest pain syndrome, or ICPS as they call it. The enthesopathies or tendinopathies are is a considerable number of regional pain syndromes, but again, their role in low back pain alone has not been established as pain generator. So the authors of this review article evaluated the ultrasound of the iliac enthesis of the rectus spinae muscle in 60 low back patients and 50 controls. And all of the patients had clinical signs indicative of low back pain caused by unilateral ICPS, and this syndrome was first described by Coley et al. The enthesis at the painful side was significantly thicker when compared to the non-painful side. Moreover, the painful enthesis had significantly more elementary ultrasonographic lesions. This was defined by Tersley et al. And the lesions were hypoechogenicity, altered fibrillar structure, cortical irregularities, or hyperecho focus in the enthesis in both the control group. So the conclusion from this pilot study that the enthesopathies of the ES could be because of a discrete cause of low back pain, and which could be identified by the ultrasound. So coming to the critical analysis of the article, you cannot draw definitive conclusions because many reasons. The number of studies on the diagnostic modalities is very low, relatively quite low, compared to the conventional modalities which are being followed since ages. Most of these studies only have historical significance because they were quite old. The newer studies have been comparing, but with US, the ultrasound is still not comparable to the better, more extensively diagnostic tools available, that is the MRI, CT, myelography, discography, etc. So the current stand of the American Institute for Ultrasound in Medicine is that the use of spinal and paraspinal ultrasound in adults for only diagnostic or screening evaluation should be considered investigational in low back pain. Again, better designed research projects should be conducted to evaluate the efficacy of the diagnostic spinal ultrasound examinations in the near future. So I think the take-home message from this would be that ultrasound has many benefits: low cost, lack of radiation exposure, and greater visualization of the soft tissues. And this makes ultrasound to be rapidly and easily available, more likely to be used to examine or diagnose low back pain, provided we have very high quality evidence available for the same. Thank you.
Thank you, Dr. Akhil, for the excellent presentation. I will now request Dr. Aanchal to start sharing her screen, and so that I can introduce her. We will take the questions in the end. Aanchal, I have made you the co-host. While I will probably Pranchit, can you hear me?
Yeah, I can hear you. Actually,
There's some issue with the system.
I know it's just I'm still on my way
Okay.
home, and I pulled my car to the side. I've still not reached home, so I'm just joined with my
Okay, we
my
can see
phone.
your screen. You can keep your video off to
Can you
conserve the.
share my screen?
It's already.
Yeah. Can you see my screen?
Yep. It's already shared.
Yeah. Okay. And you can hear me well?
Yeah, I can hear you well. That's a good location.
Okay. All right. So I'll just keep my video off and I'll start. So
That's
this
good.
is my introductory screen.
Yeah, so Dr. Aanchal Sharma has done her MD anesthesia from PGI Chandigarh. She's done her fellowship in pain medicine from Chicago, United States. She's board certified from American Board of Pain Medicine. She's a senior consultant and head of department at the Department of Pain Medicine and Palliative Care at BLK Max Super Specialty Hospital, New Delhi, and Venkateshwar Hospital, Dwarka, New Delhi. So over to you, Dr. Aanchal.
Great, thank you. So I can't see the top of my screen. So we are presenting this journal, Perspective of Ultrasound Guided Interventions. This was published in 2015 in Indian Journal of Radiology Imaging. And the authors are Dr. Aditya and Dr. Alpana. And this was an observational single center study, which was done at Department of Innovation Imaging, Musculoskeletal Imaging, Sports Med, Mumbai, Maharashtra. So the basis of image-guided intervention is the ability to reliably identify the region to be injected, what we call as target, and confirm our placement of the needle and other intervening device at the appropriate location. So that's why ultrasound is ideally suited for all MSK intervention, as it is convenient, inexpensive, safe, and there is lack of radiation. So aim of this article was to discuss the numerous ingenious ways in which ultrasound is being used for therapeutic MSK interventions in current orthopedic and sports rehab practice. So the authors, they are mainly from the orthopedic department. They're taking care of the daycare orthopedic center. So that's why they are, they have the conditions they have presented is mostly, what we use in current orthopedic and sports rehab practice. So they have shown the use of ultrasound in MSK into the areas of muscles, tendons, sheaths, ligaments, bursae and ganglia, joints, bones, and nerves. So general considerations they have given is, first of is partnering and practice building. So, this will take good clinical assessment, generating patient confidence, coordinated diagnostic and rehab plan with the patient, with the surgeon is, paramount in developing a successful practice. Second, they tell what kind of transducer to be used. They say that high frequency, which is 7 to 12 megahertz linear array transducer, if you have to visualize superficial structures. For deep structures like hip joint, which require greater penetration and lower frequency, the curvilinear probes. And then there are a third kind of transducers called as hockey stick ones, which is used for imaging of superficial structures, which involve small or irregular paths, which have kind of smooth surfaces like finger toes, where your other probe will slip off. So, in these we use hockey stick. So, pre-procedure diagnostic assessment. A detailed pre-procedural ultrasound examination is very important for area of interest, which includes color Doppler to identify and characterize the target in relation to the neurovascular structures before we even plan to put the needle in. Written informed consent, explaining all the procedure risk is also necessary. Sterility. They say that cleaning the area thrice with iodine solution and then subsequently cleaning the site and transducer also with generic 75% propranolol or other disinfectant. The antiseptic skin solution also provide a fluid interface for optimal visualization of underlying structures. And the jelly deodorant provides a thick interface. Then, of course, sterile gloves, drapes, probe covers, etc. So the next point is needle selection. So based on the type of intervention, you choose your needle. Either you choose large size needle, 16 to 20 gauge, if you have to aspirate a thick material like pus, ganglia, fluid, or organized hematoma. If, you otherwise smaller needles are sufficient for most of the injection, which is 22 to 24 gauge. They use 22 gauge rather than 24 so that it doesn't bend and, it's better, allows straight trajectory and accurate placement. So technical tips for, doing the procedure. Needle is best visualized when its long axis is parallel and in line with long axis of the transducer. And if you follow my cursor, this is the first picture. You can't see the needle because even though you see the picture perfect, this is the, right elbow, it is planned for doing a lateral epicondylitis But if you see the second picture where they have just, done some correction, you can see at least, bit of a needle. So they say if the needle may be difficult to identify, you hold your needle steady and try to move the transducer and bring it in line to the longitudinal axis so that, you can see your needle. Or the needle may be repositioned according to the longitudinal axis of the transducer. If you can't move your transducer, if you have just seen the best picture in that view, so try to move your needle. So marking the skin site prior and introducing the needle as close to the transducer also ensure the better needle visualization. So injectables, we use local anesthetic, lignocaine. Onset is 1 to 2 minutes and duration is an hour. Bupivacaine onset is 30 minutes. It may last up to 8 hours. Ropivacaine and bupivacaine are the preservative-free forms. They cause less motor blockade. So it's better for perineural or post-op analgesia. Ropivacaine, we know it's less cardiotoxic and chondrotoxic. This is when we use it for, intra-articular. So, we need something which is less chondrotoxic to the chondrocytes. Levobupivacaine is less cardiac and neurotoxic. Intra-articular local anesthetic injection, have been reported to cause chondrolysis, and therefore they should be diluted with normal saline rather than giving them pure, especially in the large joints where you actually inject larger volume. This is a very important point, actually. We kind of inject it just like that, 10%, 20% without thinking. So this was a good learning point that actually intra-articular local anesthetic can cause chondrolysis. Most commonly available local anesthetic are methylparaben, has a methylparaben as a preservative, so which can be neurotoxic. So better for perineural injections, just to find some preservative-free forms. Then steroids, they are potent anti-inflammatory and pain-modulating drugs. They can be injected into the articular, periarticular area, intra or peritendinous, soft tissue structures. Hence, they are very useful for any kind of arthritis, bursitis, tenosynovitis, tendinopathies, tenosynovitis, entrapment neuropathies, or ganglion aspirations. But we need to know that it takes 48 or to 72 hours for them to be effective. The goals of injecting steroids are short-term and medium-term pain relief, reduction of inflammation, and improved mobility. An important point is that steroid injections do not provide long-term pain relief. So they usually do not alter the course of underlying disease. Hence, when you inject steroid to decrease the pain, it should be used in conjunction with the rehab exercises. The complication of injecting steroid, most commonly sterile synovitis, which is a post-injection flare. This is the most common complication following an intra-articular steroid injection, and this is mostly attributed to the particulate nature of injectate. Less common side effects seen are effect of articular cartilage like thinning, chondromalacia, tendon rupture if the injection was intratendinous. Local intradermal and subacute injection can cause local skin atrophy. This is more when you actually inject in very superficial area, like for lateral epicondylitis. I've seen, patient coming with just white skin over the lateral epicondyl, because of the skin atrophy and fat necrosis. And then, of course, skin depigmentation. Less soluble branch hydrocortisone esters like triamcinolone, which is available as Kenacort or methylpred, remain at injection site longer. It has longer duration of action, but it more likely causes cutaneous adverse effects. So most commonly used steroids are triamcinolone and methylpred. Triamcinolone is preferred because of longer duration of action. Methylpred is less soluble, shorter acting, but less prone to skin atrophy. And so it may be preferred when you are actually using it for near the skin surface. Betamethasone has high solubility, rapid onset of action, less cutaneous side effects. So it is preferred when you need soft tissue injections. So degree and duration of symptom relief also varies depending upon what condition you are using it for. Repeat injection is, only if relief was after the first following a single injection. There is no fixed consensus so far on the frequency and interval between repeat injection, but an interval of 3 months is usually preferred among the pain physicians. So another thing is autologous blood and PRP. So it contains fibroblast growth factors, which actually restart a healing process and modulate tissue healing. It has been successfully used in the treatment of refractory medial and lateral epicondylitis of elbow. Refractory, the term used for if it is, it does not respond to conservative measurement like NSAIDs or rehab, or it has not responded to steroid injections. Then second is rotator cuff tears, chronic tendinopathies at any common flexor extensor region, hamstring regions, patella, Achilles tendon, promoting bony proliferation and healing articular cartilage, like in knee arthritis. Then, how you take the PRP is you take a large volume of blood, put it in a centrifuge, and concentrated platelets are harvested. Around 3 to 5 ml of PRP is locally injected into the injured tissue, and it modulates tissue healing by release of growth factors, like multiple growth factors written here. And the most common complaint is pain at the injection site. And you get it because of ensuring the local acute inflammatory response. This process is contraindicated in patient having thrombocytopenia or platelet dysfunction. Then prolotherapy is injection of an irritant solution, which is called as proliferant, into the tendon or ligament, and it incites a local inflammatory response, which actually proliferate fibroblasts and collagen synthesis, and hence encouraging healing and restoration of tensile strength. It has been successfully used in various MSK syndromes like intervertebral disc disease, for mechanical low back pain, plantar fasciitis, refractory tendinopathies, osteoarthritis. And prolotherapy, they say it may be supplemented by agents like PRP. Viscosupplementations, intra-articular injection of hyaluronic agent derivatives. It has been popular for osteoarthritic symptoms only, mechanism not precisely understood, and it aims to replace what is believed to be an important factor in joint lubrication. So when you do all these injections, what do you do, post-procedure injections? If you have injected steroids, then patient is advised to limit activity for 48 to 72 hours. Local ice pack analgesics for any post-injection flare-ups, which you may see for a few hours when local anesthetic effect wear off. And following PRP or prolotherapy, you usually tell them to rest for a period of 1 to 4 weeks and then graded return to activity, and involving a good stretching program followed by eccentric loading program. Avoid using NSAIDs for pain relief or post-PRP procedures because they inhibit the PRP facilitated or dextro-stimulated inflammatory reaction, which is the basis of tissue modulation. So intervention in muscles in acute or subacute grade 2 or grade 3 intramuscular injuries where there is no tendon avulsion. PRP is increasingly used for better pain relief, faster healing, quicker return to the play. But if there is associated hematoma, they say aspirate prior to the injection and then inject 5 to 10 ml of PRP depending upon the site of the injury. Then you can use steroid anesthetic injection also for early pain relief and rehab in these muscle injury. But the problem is delayed healing scar formation, thereby risking the re-injury. If there is chronic injuries in the muscles, then they present as focal area of persistent pain. They are identified by ultrasound. Treatment is ultrasound-guided trigger point injection. Then intervention in tendon and tendon sheaths. They recommend assess the tendon first, and you can do it using the ultrasound. It is to ensure the tendon is not at risk of further damage and there is no ongoing infection. But for larger tendons like hamstring, they suggest MRI should be done, especially if one is not confident of using sonography as assessing the morphology. For acute or chronic tendinosis, this is because of repeated stress. Here, the injection is to break this cycle and to allow the appropriate rehab. An ultrasound-guided steroid injection can help into the tendon sheath or adjacent bursa, followed by rest and physiotherapy. Steroid injections have, given improvement in decurvain tenosynovitis, trigger fingers, tenosynovitis of flexor helicis longus, peroneal tendons, rotator cuff tendon, all kind of, tendinosis. So a tendon sheath injection. So like biceps tendon is identified in transverse in the bicipital groove. It's placed well in its intraarticular portion in rotator interval, where you target peritendinous steroid injection. You can see this is, long head of biceps tendon, and you can see the needle coming in, and you are injecting into the biceps tendon, around the tendon. And then peritendinous, you can see, lateral malleolus, peroneal tendons, and you can see this needle coming in. And when you inject into the tendon sheath, it is called as peritendinous injection. And then intratendinous, you can see this is the tendon. This is peroneal tendon only. a needle is coming into the tendon when you inject, especially PRP in case of peroneal tendinosis. And then peritendinous injection is also used for trigger fingers because it is also a tenosynovitis of digital flexor tendons. And you can see here, the right hand palmar aspect, where you would expose and put your ultrasound in. And then this is the post injection. You can see this fluid deposited around it. This is the tendon, and above the tendon. So this is the benefit of using ultrasound. You can clearly see the tendon, and you don't risk putting steroid into the tendon. Then persistent recalcitrant tendinopathy. If pain is persisting despite multiple steroid injection, that means tendon is thought to be stuck in a state of disrepair. And PRP injection are thought to kickstart this, accelerate the healing cascade. In such situation, what you do is injured tendon is gently or vigorously needle, depending upon how big the tendon is, to recreate an injury. And then PRP is injected into the tendon, which act as a catalyst in recovery. But PRP is at least given 4 to 6 weeks after you have given the last steroid injection. There is no fixed consensus on the need and interval of repeat PRP injection for tendinopathies, but they have given their own. What they do is, they say in our practice, they assess patient 46 weeks. This is like, 10, 11 months after the first PRP injection to quantify symptomatic relief. If the patient has gotten significant relief, which they say is above 80%, then single PRP is good enough, followed by rehab. If it's partially responsive, then you can do second PRP injection, especially if the rehab has also not increased the pain relief. But if the patient has been unresponsive or less responsive, like less than 20%, then they said there is no point of giving further PRP injections. Prolotherapy, they follow the same principle as to the PRP, except that they are irritant. Commonly 15% dextrose or normal saline is injected to initiate this inflammatory response, reduce re-injury. And various studies on efficacy of prolotherapy has been used in management of chronic tendinopathies, but there is no enough data to develop an appropriate treatment regimen, like volume and how would you repeat it, etc. Sclerotherapy, so neovascularity has been associated with painful tendinopathies. An injection of sclerosing agents into these neovessels has been attempted. And the theory behind this is sclerosis of neovessels in inflamed tendon and possibly the surrounding nerves is responsible for pain relief. So if you sclerose this, then neovessels, then probably pain will go away. And polidocanol is widely used as sclerosing agent and has been tried in the treatment of patellar and Achilles tendinopathy with promising results. So while reading this article, this is the first time I've heard this polidocanol. So I, put up this picture just, if some of the listeners are, figuring what this could be. So this is available in India, but, we have never used it. So fenestration or percutaneous stenotomy, chronic recalcitrant tendinosis, especially, common extensor tendinopathy. Since the pathological tendon can be identified under ultrasound and patient is able to target the specific site of pain, an ultrasound-guided tendon using an 11-gauge scalpel or just the repeated fenestration of tendon with needle can also be performed. The goal is to convert the chronic non-healing injury into the acute one. And during this fenestration, the overlying area is anesthetized and injured tendon is needled to create a small fenestration and induce the bleeding, resulting in local release of platelets and growth factors. Tenotomy procedures can be performed independently or along with PRP or dextrose injections, and the studies have shown good results. There are certain newer advances like matrix metalloproteinosis have been implicated in chronic inflammation. So local injection of these MMP inhibitors have been shown to modulate tissue healing, and this could be an alternative treatment for chronic tendinopathies. This is an example, aprotinine triazolol, which is a broad spectrum MMP, which has been, which was normally used for cardiac surgery, but you can use in peritendinous space as well. But the main side effect is hypersensitivity reaction. And so recurrent use is, strongly contraindicated. And the authors say they have never used in their practice. Calcific tendinitis. This is because of the calcium hydroxyapatite crystal deposited, especially in the rotator cuff. This is the commonest site, kind of critical zone of the supraspinatus zone. And pain is because of the leakage of these crystals into the adjacent synovium. And the period of worsening pain first comes, and then there is improvement with organization, and then the resorption of this calcification. This is a usual picture, but except in some, they develop chronic pain, disability, and functional impairment because of this pain. And then symptoms, imaging appearance, and physical consistency is based on what stage of calcification you're seeing the patient, whether it's pre-calcific, calcific, or post-calcific. And treatment is usually, approaches hyperacute and acutely symptomatic stage includes you do peritendinous or bursal steroid injection and local anesthetic injection to alleviate pain and ask patient that pain condition is usually self-limiting. It will just take time. And in subacute, this was for acute, but if it's subacute and chronic cases, you can do barbiturate, barbiturate, and it involves advancing 18 to 20 gauge needle, so bigger size needle into the calcification and pulsing it with a normal saline to dissolve the non-soluble calcium into the soluble hydroxyapatite and calcium chloride. And this is followed by steroid injection. So, this is sometimes challenging because calcification could be mature, ossified. And so X-ray is needed to determine the character of calcification. And the author says they have attempted barbiturate therapy for chronic calcific lateral epicondylitis in one case, and there was size reduction in the size of calcification. So coming to the ligaments are similar to tendons, and so they use ultrasound-guided PRP injection also have been used in rapid healing of ligaments. You can see this is the femur, this is the MCL ligament, and you can see this needle coming into the so diffusely thickened and altered ecotexture of MCL. You can see this arrow, you can see this tear, and then you bring the needle into, and you do intraligamentous PRP injection, especially in the acute injuries. And this targeted injection is given at the site of injury. And then this Pellegrini-Steeda lesion, this is the calcified focus within the fibers of MCL is called this Pellegrini-Steeda lesion. You can see this calcification. This is femur, and you can see this MCL calcification, and needle is coming directly into this calcification. So local needling of calcification followed by steroid injection can be done in some cases which are unresponsive pain. So next is bursa and ganglia. Bursa injection is usually done for subacromial bursa of the shoulder, greater trochanteric bursa of the hip. And the knee joint also, it has been done for bursa and semimembranous medial collateral ligament bursa, Baker cyst, etc. And the picture is showing the same supraspinatus tendon. You can see, this is supraspinatus tendon, and this is subdeltoid bursa, and you can see this thin line, which is a bursa, and here the fluid has been injected. Then the ganglia. Ganglia is just the outpouching of synovium or degeneration of fibrocartilage in the ligaments, and pain is because of the lesion itself. Degenerate or tear, or sometimes it causes the mass effect on adjacent structures. Ultrasound examination helps identify this ganglia and differentiate it from intrafiscally located. And you can see one of the example. This is the femur, this is the cyst, and needle directly coming into the cyst. This is the ACL cyst, the ACL ganglion. It is seen as hypoechoic intra-articular area when scanned from the posterior. So patient is lying prone. This is femur, this is tibia, and into the in between those you can see this ganglia, and the needle is coming into the ganglia, and the post aspiration you can see this is almost reduced to negligible size. So next is joint aspirations. You can use ultrasound to the targeted approach for deep-seated joints like hip, shoulders, and also for smaller peripheral joints like acromioclavicular and smaller joints in hands and feet. It gives you an additional advantage of real time, and especially when the needle is can be manipulated under an osteophyte or a spar during the procedure. This image shows the accurate needle placement into the glenohumeral. This is the joint space, and this is the needle coming in. So, and the smaller joint also. This picture is showing the calcaneocuboid. This is calcaneum, this is cuboid, and this is the osteophyte. So if you see the osteophyte, you can just, bring your needle, you can kind of play around with the path and, just play around with the osteophyte and bring your needle into the joint actually, the real-time visualization. Volume, they say, if larger joints, around 10 ml, smaller joints of hands and feet, less than 1 ml. But most important in choosing the volume is injection should be terminated if the patient complains of excessive discomfort while you are injecting. You can use steroid, local anesthetic for short and medium-term relief, and it is beneficial for acute inflammatory monoarthritis, osteoarthritis, frozen shoulders, because it decreases the inflammation and prevent the capsular adhesions. But the patient should be counseled that steroid injection can decrease pain, but they do not alter the course of underlying pathology, except in inflammatory articular disorders. Then spine injection, you can do USG-guided facet injections, which, accurate needle placement in the facet joints, especially in arthrosis, USG-guided SI joint, when patient is lying prone, and 4 to 5 millimeter hypoechoic cleft is seen between linear echogenic lines in sacral ala and iliac crest. So I just use this picture from NYSORA because it is just hard to explain just with the theory. You can see this sacrum. This is freely available in the NYSORA website. This is the ilium. And if you see into the ultrasound, this is the ilium. And this is the sacrum ella. And you just bring your needle in. When you put your needle like this, then the injection is in the lower part of the joint, approximately 1 centimeter above the lower end of the joint. But the SI joint could be in the close proximity to the sciatic nerve. So we need to be mindful of that. Then intervention in the bones. The studies have suggested PRP injection can enhance the rate of healing in non-united fractures of long bones. And author says, in their practice, they have occasionally injected steroids and local anesthetic for painful avulsion injuries of distal fibular tip, coronoid process of ulna, medial, and lateral epicondyles for symptomatic reliefs. But they don't talk about the PRP into the long bones. But there is limited data available on that. Intervention in nerves. We all know that peripheral nerves appear as salt and pepper-like appearance, and we have discussed that what kind of transducer to be used. In acute pain management, they have given examples like you can use for post-op or post-traumatic, like axillary for upper extremity, interscalene suprascap for shoulder, femoral and sciatic for knee and foot surgery. Sciatic nerve can be given in subgluteal space, where the nerve is located deep to gluteus max muscle between ischial tuberosity and greater trochanter, what we call as subgluteal block as well. And then distal sciatic block, which we call as pop sciatic block. And then, being this is from the authors, being in an orthopedic setup, we give post-op femoral nerve blocks on a daily basis in all patients for ACL grafting to minimize post-op pain. And in 2015, this article was published. So probably they started using the triple blocks recently at that time, wherein the iliac facial plane was injected with local anesthetic, and it aimed at blocking femoral, obturator, and also potentially the lumbar plexus for better pain relief. And iliac facial plane is a large volume block. This is a picture which shows artery, vessel, and nerve. And this is the needle which comes in. And this is the femoral nerve. And this is the post injection. So perineural steroid injection for chronic, this was acute pain. And then the chronic pain, you can use ultrasound for things like motor neuroma, metatarsopharyngeal joint synovitis, intrametatarsal bursae. This is the, motor neuroma. It is seen as a hypoechoic nodule between second and third metatarsal. This is the needle coming in, and they have injected, probably some air has been injected as well. And then the medicines is injected, and this hypoacute nodule is gone. And then you can use it for carpal tunnel as well. So limitation accepted by author is none. Critical analysis, it actually gives a brief overview of potential ultrasound in managing MSK conditions, especially pertaining to internal derangement. It's a basic overview of if you want to start and develop USG MSK interventional practice, then this article kind of help you guide your beginning practice. But labeling, as you could see, I had to mention it, labeling of pictures is not quite visible. So it was very hard, that could have been done better. And they don't discuss any protocols regarding their procedure. the procedure they are doing, they don't discuss, what kind of protocols they use for them. And then take-home messages, image guidance obviously improves the accuracy of tissue sampling and delivery of our agents. And large portion of MSK is easily visualized under ultrasound guidance, and it is an easily available, safe, easy to use modality, making it amenable for a huge variety of image-guided procedures of MSK system. Thank you.
Thank you very much, Dr. Aanchal. I think now we just go on with the with the faculty introductions. I had just paused it because I think Dr. Sahoo had not joined, but it seems like he won't be able to join. So I will just share my screen. I hope you all can see my screen. I will introduce our faculty who is here with us. So Dr. Taruna Penmetcha, she's MD and she's a division chair in acute pain and associate program director pain fellowship, Department of Anesthesiology and Pain Management at Chicago, Illinois. And she's also the adjunct associate professor, Department of Anesthesiology at Rush Medical College, again at Chicago, Illinois. And she's a chair of hospital-wide committees, chair of the analgesic and symptom therapeutic subcommittee. She's got multiple publications in peer-reviewed journals and recognition for service rendered to the pain fellowship and patients. She's also received the Attending for the Year award in the past. So, Dr. Taruna, would you like to add anything or ask any questions or lead the discussion? Over to you now, ma'am.
Sure. Well, first of all, I would like to congratulate both the speakers, Dr. Bhalla and Dr. Sharma, for a very detailed, review on the topics that were presented. And it is very important to understand that the first article that was talking about low back pain, ultrasound, obviously it is a good modality to have and can be used as a screening tool when you're doing your procedures, but to use it as the sole modality in the era where we have MRI and CT scan to diagnose a spinal stenosis, if we are still way away from making it as a diagnostic tool. We have to, a lot of the evaluation by ultrasound is operator dependent and also depends on the body habitus of the patient, which may sometimes be an issue for visualizing deeper structures or looking at the spine. So we have to be cautious when we use it as a sole modality, as a diagnostic tool. The other article that Dr. Aanchal presented, we have, definitely for musculoskeletal ultrasound, I'm sure most of us are using the ultrasound guidance for our joint injections, for tendon and muscle injections. And it is very feasible, it is really accessible, and we should stop or move away from blind procedures if we have access to ultrasound, just because it makes it more targeted, more specific, and prevents a lot of complications. Whether, it is very important to familiarize ourselves with the anatomy when we are using the ultrasound, because unless you know the anatomy, you can start imagining things on the ultrasound. So everybody who's starting the practice of ultrasound, try to scan yourself, try to scan your friends, and try to get familiar with the anatomy. Even before you're doing a joint injection, try to scan the area around to look for popliteal cyst, to look for meniscal tears, and get familiar as you do it.
To identify and characterize the target.
I don't know, I was hearing somebody in the background. So also important to understand that whenever you do these MSK guided procedures, don't forget physical therapy. Don't forget sending the patients for physical therapy, because injection by itself is not going to give you long-term benefit. So all these patients need to be followed by physical therapy. I think that's all I have to say.
Okay, great. There are some questions which we will take now from the audiences. So I think a few of the questions have been answered by Dr. Akhil. One was, can we give paracetamol tablet after PIP for plantar fasciitis? And I think the answer is yes, you can do that. Even you can give tramadol. So usually we avoid NSAIDs, but other than that, you can give whatever you want to. I think another question is, Dr. Akhil, there is one more question. I didn't understand that question. but
Uh,
probably, yeah. Can you just
So
take?
I had asked that also precisely what has been asked. He has said that has this been tried for cervical spondylitis, but he has not mentioned what has been tried for cervical spondylitis.
Okay, so
I'm
we'll
guessing he was asking PRP
So
maybe.
Tejas, please type your question in more detail. I think we can't decipher that. Dr. Akhil, what about this transforaminal question? But yeah,
Again, that was not a specific query. So he had asked what is the cutoff diameter for the spinal canal for the critical diameter, and uh, ideally it is kept as 14, but it is not exactly that sweet that we can claim it to be exactly 14. But his question is that if it is less than 14, are we not supposed to do a transforaminal epidural injection? And I feel that is a very broader question, and I don't think that would even justify doing a TEPC just because the spinal canal diameter is less than 14. I think most of the injections we do are because the spinal canal diameter is less than 14. That is where the pathology starts. I think
no, I think
that
there are very clear cross-sectional area classifications. However, the indication for the injection is not solely, or the procedure is not solely the diameter, but that is actually a finding once you do the scan secondary to the symptoms. So the what they have described is a cross-sectional area. So usually they say if it is less than 100 square millimeter at the narrowest point, or if that is known as that it is reduced, so it is known as stenotic, and maybe around 75 or 76 is moderately stenotic, and if it goes below that, then it is severely stenotic. So it's the cross sectional area rather than, some classifications they prefer that. And I think if you have a stenosis, then epidural steroid has a anyway not the first treatment of choice, or rather a dubious mechanism. It's more for an inflammatory pain that you will like to use a steroid injection, and not for something which is a stenotic symptom. For that, you will need some form of decompression per se. Anyway,
visualizes.
yeah, so I think we'll take one more question, which has come up from our audiences which are watching right now on the Facebook, and they're asking rotator cuff, what volumes do you inject in rotator cuff injections? And I mean, they say that it is painful. So what do you do when such painful injections are there? And that is the question. So we'll first go to both of you, then we'll ask Dr. Taruna, and then I think we can close. Dr. Akhil, Dr. Aanchal, what are you doing with the rotator cuff or shoulder injections? Let us take shoulder injections in general.
So for rotator cuff, ma'am, go ahead.
No, I'm just rotator cuff PRP. I usually do 4 to 5 ml, but for a broader shoulder, like frozen shoulder, you do a hydrodissection. You use a bigger volume, like 20-25 ml, or sometimes even you just had to see that that capsule getting dented. That adhesions getting broken up, because you directly see in the under real time visualization that your capsular is getting distended. So that is what I do. I usually don't do rotator cuff intratendinous steroid injection, but sometimes if we have to do for bursitis, then I usually do 4 to 5 ml of volume.
So my take on this is that there are two schools of thought on it. One is directly inject into the tendon which is involved in the rotator cuff, or the other is bathe the tendon from both the aspects. One is from the glenohumeral joint, and the other is from the SASD bursa, which will cover the tendon. So both the schools of thought are there, but again, the amount of volume you'll have to put in the glenohumeral joint will be more. And then you might have to choose between intraarticular steroid versus prolotherapy maybe with dextrose. But it is totally operator dependent. And I would prefer, if putting more volumes, I would go for a prolotherapy with dextrose. But if I'm giving lesser volume directly into the joint, I'll prefer PRP.
Dr. Taruna would like to add something, ma'am.
Yeah, so I would not comment on prolotherapy. I don't have experience with it at all. We are using mostly radiofrequency ablation for rotator cuff injury. We are doing suprascapular nerve and axillary radio frequency ablation. Not using PRP as much because our population in Cook County is not, it is all cash pay. So we don't have that kind of population. So we are not doing a lot of PRP. So I would not comment on that either.
Ma'am, can I ask you something?
Sure.
When you're doing radio frequency ablation and you are not doing any regenerative procedure per se, so the tendons do heal even just with a radio frequency ablation over time?
No, so the patients go for extensive physical therapy and radiofrequency. We do steroid injections for glenohumeral joint, and that's what we do in the beginning. But then radiofrequency just provides them long-term pain relief so they can participate in physical therapy. There is no regeneration without the PRP. We don't do prolo and we don't do PRP at all.
So, ma'am, there are some studies where, like rheumatology has conducted some studies, physiotherapists have conducted studies where the tendon heals on its own, even when you're not going for some intervention per se. So maybe
you have adhesive capsulitis and the patients are participating in physical therapy. So there is this freeze stage and thaw stage, and it just takes longer duration or longer time. And with PRP, you fasten the healing process. You bring all the inflammatory mediators in the area and you start the healing process. But without that, it is going to be a long process. It can be a year before the patients recover completely or get the range of motion back.
Thank you.
Great. So I think Dr. Tejas has come up with his clear question. He says that what about ultrasound-based steroids or PRP for cervical spondylitis or in the cervical region? Dr. Akhil, Dr. Aanchal, anyway, you want to answer that?
Sure about the use of ultrasound for injection in cervical area. I think it is dependent upon the operator's experience with the ultrasound in cervical spine. So for me, I feel more comfortable with fluoroscopy at this point, but yeah, we are getting more and more familiar with the ultrasound for cervical spine too. Trigger point injections, injections for cervical dystonia, those are done with ultrasound. But if you're talking about epidurals or transforaminals or medial branch blocks, then I would still maybe favor the fluoroscopy guidance more than ultrasound guidance at this point. I would like your opinion. I mean, is anybody doing any injections in the cervical spine with ultrasound guidance?
So, ma'am, we do extraforaminal injections, but only when it is very difficult to get to the patient to the OT suite, maybe, and which is very rare. And again, the pathology is not addressed when you're doing an extraforaminal injection with the ultrasound. And again, fluoro, I think, is very necessary in the cervical region because it is a highly vascular area and very important vessels are around. You cannot just assume that you are in the right place and not check on the fluoroscopic shoots. So I think it is very important to do it under fluoro.
Definitely.
So all my diagnostic facet for ultrasound, if they are going to be there, it will be done always in ultrasound. And the other ones I will not do with ultrasound. Cervical transforaminal or periradicular injections I find quite risky, although it's very easy to demonstrate in a volunteer while we are doing the workshop. That's a separate story, but I would not risk, my injectate, putting some needle there and then, doing a periradicular. But of course, if Dr. Sahoo would have been able to join us, he just messaged me that he's having some issue, but then probably he must have, enlightened us more on this, but maybe some other day. And it's very important that we are more safe than probably sorry. And even the interlaminar one is even at the lumbar level, it's more of a guidance at this point rather than the actual procedure being very comfortably being done by many people. So of course some people do it, but then as you said that it's all a matter of expertise, and if you're doing it regularly, then you're of course more comfortable with it. So that's our perspective.
OB epidurals, we are using ultrasound quite a bit for guidance because we have high
Guidance.
BMI patients. But
Yeah.
besides that, in the pain clinics, mostly it is, so far we are doing X-ray guidance. There are certain procedures that we have moved towards ultrasound guidance, but mostly musculoskeletal, maybe stellate ganglion blocks and, genicular nerve blocks for the knees and things like that. And obviously head and neck procedures. We do a lot more ultrasound guidance.
So I'll share one experience. Very recently, I was called up by a regenerative clinic to do this ultrasound guided uh, epidural in the lumbar region, and the patient had three sittings. The first sitting was very uneventful. I could easily locate the lamina. I could go past the lamina by direct visualization. I injected the PRP very nicely. It was like a 5-7 minutes job, and everything was done. But the same patient the next time, probably the flexion was not good enough, and or whatever. I was doing the prone position. So I took around maybe 20 minutes, and once I was injecting, I got a gush of kind of a blood which was coming back. So it was quite difficult to visualize at that particular point, and then I converted it to a blind procedure, and which was very uneventful. So the thing is, it's quite difficult still, even though I do a lot of ultrasound in my practice, and but it was still very difficult at that point of time. So probably in my experience, as we do more and more procedures and become more and more familiar, also the more and more literature, better techniques become available. So things can become much better.
Okay.
So I think, ma'am, you have any questions?
Aanchal, just one case that Aanchal actually wrote about it. It was a pregnant woman who came to the pain clinic with acute disc herniation, I believe, or it was a fail back. I'm not too sure. But the patient was having radiculopathy during pregnancy, and we did a steroid injection using ultrasound guidance. We did caudal because it was a fail
caudal
back.
epidural.
So
Yes,
caudal
correct.
epidural with ultrasound. So that was an interesting case, so that is one area, pregnant woman, where you can use ultrasound
Yep.
for
Yep. Actually, the whole practice of thinking, I don't know what's the situation in that part of the world, but probably here, if somebody is pregnant and they get some kind of a pain, so they are supposed to suffer that. I mean, because the medicine will not be given, and there's no other alternative, and so probably this can be developed into a very good treatment option, probably.
But actually, the patient that patient was already getting tramadol, PCM, the opioids, because we have more options there for opioids. But the patient was just getting bedridden, and she had a 6-year-old at home to take care of her. Plus, she was pregnant, so she requested do anything, but just because she was completely bedridden. And that one caudal epidural with ultrasound guided gave her tremendous relief for 6 months. And then she came back after 6 months when the baby was delivered. So we did fluoroscopy guided second procedure, but that case was published as well. So
she ended up having a stimulator placed already.
Great. So I think thank you all for the discussion. Thank you, Dr. Akhil, Dr. Aanchal, and thank you, Dr. Taruna, for coming at a short notice and helping us out with your insights. Guys, I think we'll just conclude today's session. And this is the season 4 of the Mumbai Pain Schools Pain Journal Club, where we are focusing on MSK Ultrasound. And of course, this season we have an 8 p.m. Indian time, and we have group topics. We have 2 faculties and 2 papers. Of course, we have the papers, of course, in advance. As the next steps, I request all of you to join our mailing list. The WhatsApp group link is already given to you in chat and email. Any suggestions, comments are welcome. Next Friday, we don't have the journal club because we are having our hands-on workshop, which is the hands-on MIPSIS workshop, which is both ultrasound and fluoro-guided tracks. So The next Friday we'll meet on 15th of December with the next topics, which I will be circulating very soon. Until then, see you around. Keep learning, guys. Bye.